I have no access to any other computer.
Okay, let me put a
Muhammad,
timer.
put the time.
Let me put a timer, please. Five minutes. Start.
Okay, hello. I want to talk. I want to talk to Mr. Smith about one of his patients, please.
Okay, I am Dr. Smith. Could you summarize your case?
Nice to meet you, Doc. My name is Orey. I'm CT2 breast registrar, surgery registrar. I want to talk to you about one of your patients. Her name is Green Grease. She's 65-year-old. She underwent breast surgery, axillary clearance and lymph node clearance of breast surgery 2 days ago. Now she developed short breath and she developed axillary swelling with the drain get fresh accumulation of fluid.
All right. And what's the concern, doctor?
My concern that her daughter, she want to take her home. She is insisting to take her home. Although we experience for her, we explain for her critical status, and also they live 60 miles away from the hospital.
But in your opinion, is that safe to send her home?
No, especially she developed. No, it's not safe, and she also developed short of breath. That will make her situation more complicated.
Right. Do you assess Mr. Green capacity to make her own decision?
Of course, I have assessed her. She has a full assessment of her capacity, but her influence, her daughter, make her cloudiness about her decision.
All right. And what did you find in her clinical examination?
Well, actually, on her clinical examination, she had axillary swelling, and she developed 90 milliliter of fresh blood accumulated in her suction drain, and also she developed short of breath.
What are the potential complications and what is your probable diagnosis, doctor?
For her situation, I am worried about her short of breath. That could be other differential, could be PE, pulmonary embolism, and could be exacerbation of chronic obstructive lung disease.
What else?
And this fresh blood, this situation should have been managed her case accordingly.
You mean there are reactional hemorrhage may be the cause?
Yes, there is reaction hemorrhage there. We have to manage it accordingly in our hospital, in close monitoring.
How can you manage this differential diagnosis as you suspected?
If we are thinking of PE and other differential left ventricular failure, we have to do CT, pulmonary angiography, and we have to do Doppler of her arm to assess the situation. And for her bleeding, we have to follow up close monitoring, and we have to do hemoglobin for her monitoring her case. And she may need the evacuation of this bleeding and revision for her wound.
You mean the patient may have wound hematoma?
Yes, absolutely, doctor.
Okay. How have you communicated this concern with the patient and her daughter?
I have explained for her and her daughter this complication thoroughly, but and even I insist for her, she is not this premature discharge. It will be affect her health, but her daughter insists that she want to take her home against the advice.
All right. And what would you do if they were insisting on going home?
Sorry?
What are you gonna do?
I will explain for her again more thoroughly, and I want to do DAMA for her discharge against medical advice, and I will explain for her that any critical symptoms happen for her, like exacerbation of short of breath, or she developed increased heart rate, her pulse increased, or she developed dizzy. She must contact with the ambulance. And also she want to they treated her there or they bring the patient to our hospital. Also we want to explain for her or for her GP this situation to explain for her more about this disease.
Sound like you have handled the situation, doctor. And the last question, what are your plans moving forward?
Well, I will explain for her again her situation thoroughly, and we want to convince her that this is the premature discharge. If she insists on that, we want to do legal form signs, discharging medical advice, and we will close, but we will convince her to stay at hospital. We close her monitoring.
All right. Will you remove the drain?
No, absolutely not. It is not now. It is not suitable to be removed. I will keep it now.
Okay, and how you can deal with it? The patient will go to the home. How you can deal with this drain?
This drain should be stay at home, in the patient, to monitoring the amount of this fluid, fresh blood comes out, and we will explain for the patient if the amount of blood increased, if the swelling increased, if her symptom deteriorated, if she developed dizzy or developed her heart rate increased, or she feel she's so ill she had to go back through the ambulance, either to be seen by her GP in the home, or she had to take the ambulance and get back to our hospital immediately.
All right. You mean that you will explain the patient how to use this drain and alarm him about any warning signs?
Yes, and yes,
Okay, right.
yes. If it is obstructed, if it is the amount of bleeding increase,
Okay.
if it has become more painful, yes.
Okay.
If the swelling increased, yes.
Thank you, doctor. You have anything you want to add?
Nothing, sir. Nothing, Doc.
Okay.
I will keep you in touch.
Okay, thank you so much.
Thank you.
You
How
have
many minutes? How many minutes remain?
2 minutes.
2 minutes. Good. Okay, I'm gonna start with you first.
Okay.
I have small points here. Do you want me to start?
No, start.
Okay, so Muhammad.
Kamal, yes.
Good presentation. Very good.
I will try to summarize, but it is full of, trying to summarize. I will try to explain it more in English, but there is some spelling mistakes. I know that.
Yes, there's a small mistakes here and there, which we will work on them together. I like the way that you insisted to introduce your name, even though Muhammad tried to like distract you in a way. You insisted to introduce your name. So he told you, okay, I'm Dr. Smith. What's going on? You said, my name is... all
right, I suppose. Yes, in the school. That's all right, or team is something like that, yes.
Please mute yourself.
Muhammad tried to distract you, not to introduce yourself, but you introduce yourself anyways, which is very good. So you said, Muhammad said, okay, tell me what's going on, and then you said, okay, my name is. So you insisted in that one. But her daughter influenced her decision. I think she's clouded her decision. I don't think you said this sentence right.
Yes, I tried to remember it. Her influence make her cloudness. I think that written in the school.
Yeah, you know what? You may think, okay, her daughter. I think the influence of her daughter clouded her decision.
Yes, exactly. Yes. I'm trying to be more useful with this English abbreviation.
And then reactionary hemorrhage. When he asked you about reactionary hemorrhage, you took a couple of minutes or a couple of questions to reach the reactionary hemorrhage, but you should say as a start. And also the hematoma part. When you're afraid of the hematoma, should stay to monitor. Develop dizziness, I think, instead of develop dizzy.
Okay.
That's not develop dizzy. But overall, very good presentation. That's very cool. It's just small mistakes here and there, which is fine. We all do this mistake.
Appreciate it, Doc.
Yeah, just try to memorize the sentences so you don't suffer in the exam. You just say them. Okay, Muhammad.
I think you mentioned all of my point. I would like to mention it, but Muhammad Kamal, in the preparation station for the phone call,
yes,
I will give you a tips and tricks to easy memorize the station. Hold your pen and paper and write 3 column or 4 column. Start by write the page by my role as CT or house officer or registrar, and then the main complaint, then patient details, which is main complaint, investigation, examination, and the action that you did for this patient. And the cause
This in
of
phone
your
call, you mean, or just in phone call?
in phone call, just.
Okay.
And the cause of calling the consultant.
But am I allowed? This is my question. Am I allowed to
Yeah,
have
you
a
can.
pen and a paper?
Yeah.
Yes,
Yeah.
in the preparation station, you can hold your pen and paper and write all what
And
you
I
want to write.
can write this notes even outside the station because I
Yes,
haven't taken the exam.
yes. In the
You'll
preparation
have in the
station.
preparatory station. You can write your notes. You have 9 minutes at the preparatory station. You can write whatever you like, and then you will go to the next one, which will be the phone call will be in that one. The phone will
Yes.
be on that one. And the file again will be on the other one.
Yes.
I'm just going to mention one point here. During my exam, the file, there was a fluid chart. We lost the fluid chart. Some of the examiner, some of the examinee, some of the exam candidate before me or before, like, I don't know exactly what happened. He took the paper and he threw it. Yes. So we couldn't. When the examiner asked me, can you please mention the fluid chart? I told him I don't know. He told me, is your patient dehydrated? I said I couldn't know because there is no fluid chart. He said, no, the fluid chart is in the file. I told him I couldn't find it. But at the end, they gave everyone the mark for that question. So everything could happen during exam. You may lose the file. Someone before you may be panic. You may see someone who's crying in front of you. Someone may collapse with vasovagal attack. Anything could happen in the exam. Just ignore everything. Even if you lost the file, just try to use your brain and tell the examiner there is no file here, but from the clinical history and the examination, I think this patient will be dehydrated because he lost a lot of blood, for example. Okay? So prepare yourself for this surprising situation.
At the beginning of station, did you mention your name? My name is Muhammad Kamal. I am senior house officer working with Mr. Jack. I'm calling to speak to the on-call consultant.
Yeah.
I mentioned as in the school.
From the beginning.
As in the school. That's why.
Okay.
Yes. Not. Yeah. No. You Muhammad. You prematurely said to him, "My Dr. Seth. Okay, what's going on, or what's your present your patient?" Even though you mentioned it earlier, he insisted to present his name. He told you his name.
Yes.
I remember that one. Okay. Let's go to the
Can I
next.
ask one question? One question back before?
Yeah.
You asked me a new question. What do you do about the drain in home? Actually, I'm trying to remember this. It is not in the school. Give me the answer, please.
Yes, you answered it exactly as in my mind.
I'm trying to fix what you mean. That's why, because I don't remember there is this question in the school.
The patient's daughter.
We have to add it, Muhammad. We have to add it.
Yes, I will add it. The patient's daughter insists his mother to go to the home. So what you will do about the drain? You need to learn the daughter and the patient how to use it and when to remove it. And if there is any warning sign.
Can they have the authority to remove the drain in the home?
No. You need to.
And that's why my question.
Muhammad, it's not. Wait. It's not. The question is not like
remove it in hospital. Yes.
They remove the drain in the hospital or in the GP. Yeah, they will remove the drain in the hospital or with the GP. The question is
how they what you need to say to the patient.
How they can deal with the drain. How they can deal with the drain.
That's why this is a new question. I'm trying. I know that is a new question. I'm trying to use my clinical. I hope that I give you the answer you want.
All right.
Yes, it's the right answer.
Thank you. I appreciate it, both of you. Thank you.
We're gonna add it to school. We're gonna add it to school.
Okay. The second station is trauma referred to cardiac thoracic.
السلام عليكم.
Who will do the
معلش
trauma?
يا جماعة لو ما في مشكلة يعني ممكن أشتغل أول my station.
You are busy or something like that, Mason?
Yeah, I have to go like dehydrated. أيوة.
Trauma head.
Okay. What's the station of my son? And see, is there anyone in the group has a problem with that? If if everyone is okay, that's fine with me. I don't have any problem.
أنا
لو الناس
no
كلها
problem.
موافقة. If
I think
just right, yes, yes,
the,
yes.
the next station. Okay, all said yeah. Okay.
Okay, let's do my soon one then.
Okay.
What's her station?
Update trauma head. That's your station, my son. All right.
Okay, yeah.
Okay. Let me put the timer.
Who's her patient?
You read it from the school?
Yeah.
Okay, let me put timer.
Okay, let's. Who's her patient then? Or can you be her patient,
Yes,
Muhammad?
the examiner, yeah.
I can be Hajar, gonna be her patient then. Okay, Hajar, you're gonna be the patient, and
No patient here.
you're gonna be the doctor. Oh, I mean the doctor.
Yes.
I mean the doctor.
Hajar.
Yes, I can be the patient.
Can be the
You can be the
examiner.
doctor, yeah, Hajar.
You mean?
The examiner, the consultant.
Okay.
All right, let's start.
Open school and start.
Just a minute to open school.
All right.
Yes, we can start.
May soon start.
Okay. Hello, this is Dr. Mason. I'm a surgical clinical fellow working for Mr. Jones. I want to call to update about the patient. Can I confirm that I'm speaking to the trauma head, Mr. Jones?
Yes, it's me.
All right.
Hello, can you hear me?
Yes, it's me.
Hajar, ask her to summarize the case.
Do you hear me? I'm hearing you well.
Okay, hello, Mr. John. I'm calling to update you regarding a patient in the trauma.
Hajar, ask her to summarize her case.
Can you summarize the case?
Okay, sir. So we have a patient who's 21-year-old. He was involved in an RTA and he was admitted to the emergency with an initial GCS of 15. And after further assessment of the patient,
Ali, you mute yourself. Unmute yourself, please.
My son, your connection is very bad.
Yes.
Your connection is very bad. Can you
Can't
like
hear you.
try to... No, we can't hear. No, we can't. Try to fix your connection by going to closer to Wi-Fi or... My son, try to fix your connection by closer to the Wi-Fi. Or ask who's ever at home with you to stop using the Wi-Fi just for 10 minutes.
Hey, soon.
Maybe if she can get out and get back again, maybe it's a weak signal.
Okay, Muhammad, the connection is quite bad.
Okay,
from my son.
So
I have it. I'm really sorry, everyone, but I have a ticket. I need to get back to London, so I'm also have a strict of time. Let's go to the next station, Muhammad.
trauma referred to
And
cardiothoracic.
when my son comes back, we're gonna speak with her. Yeah.
Okay. Trauma, the cardiothoracic. I think Alia.
Put another timer.
Alia.
Is she here?
Hello.
Alia, yeah. My son.
أيوة سامعني كويس. Sorry عندي bad
No.
network.
I think your connection is bad. I think you are outside of home, right?
Yeah, أنا برا. كده
Okay,
سامعني
so
كويس ولا لسه الصوت تعب؟
yeah, now it's okay, but you need to stay in one place, maybe in a cafe or in a place that has a good connection till we finish. No.
Yeah, no.
No, your connection is quite bad. Maybe we will try with you later on. We'll move now to the next station. I also have restricted time. I need to get back to London and I have ticket at a specific time.
Okay.
Let's go to the
I'm
next.
really sorry,
Muhammad.
my son. So Alia, are you ready?
We're gonna catch it.
Alia.
Hello? Yes?
Yes, let's start that. Yeah.
Okay.
Put the timer, Muhammad.
Let me put a timer.
Who's gonna be her Hajer, can you be the consultant for Alia too? Please.
Yes, of course. But
Okay.
what's her
Okay. You can do at the end, Maysoon. Yes, that's fine.
Okay.
But try to get into cafe
Hajer-
or try to get
Hajer
into
open school.
Maysoon, meanwhile, try to get to some place that has a stable connection.
Now start, Alia.
Okay.
Hajer is asking which station, Muhammad. For Alia.
Let me check it again. Trauma refer to cardiothoracic consultant. The second station in the school.
Okay.
Can I start?
With the time,
Yeah.
Muhammad.
Start.
Hello. I'm
Hello.
Dr. Alia, senior health officer, working with Dr. Lim, Mr. Lim. I'm calling to speak to the cardiothoracic, Mr. Hamish, to ask him to accept a referral of a polytraumatized patient with widened mediastinum. Can I check that? I'm speaking with the cardiothoracic surgeon.
Yes, it's me. Go on.
Okay. I have a 45-year-old male arrived post motorcycle accident with a GCS 14, a pulse rate 120, and blood pressure 100/8. On examination, he present with swallowing left side. Chest X-ray revealed widened mediastinum with bilateral hemothorax. We insert a chest tube which drained 200 cubic centimeter of fresh blood. Unfortunately, we couldn't have a CT scan immediately as machine not working for next 6 hours. Abdominal X-ray showed an absence of shadow, and femur X-ray showed femur fracture. His blood result include hemoglobin level 8.9 gram per deciliter and pH of 7.32 with low bicarbonate level. He is also non-diabetic. We initiate fluid resuscitation with 4 liters of corticosteroid and cross-matched 6 units of blood, pending for transfusion.
Okay. Why this patient being referred?
Patient have widening mediastinum.
I see. What does the widening suggest?
Maybe patient have cardiac tamponade or a rupture aorta.
Are there differential diagnoses in your mind?
What?
A differential diagnosis you think of?
Okay, it could be aortic rupture, aortic dissection, and it could be cardiac tamponade.
In traumatic patient injury, which part is usually affected?
A descending aorta.
I see. So what's your plan for cervical, spine, and leg injuries?
I will make immobilization of cervical spine by using hard cervical collar and tape and sandbag, and for leg I use Thomas splint.
What measures have been taken for the patient blood pressure?
For what?
Patient blood pressure.
Okay. We start fluid resuscitation and prepare the blood, cross-matched blood, pending for transfusion. I will keep blood pressure within low from the normal physiologic value. I keep systolic blood pressure less than 100 to avoid risk of increasing hemorrhage.
I see. So what are the potential sources of bleeding in hemorrhagic shock for this patient?
Okay, as widening mediastinum, it's from rupture of a great vessel and abdominal hemorrhage and also side injury.
So what type of shock do you think this patient have?
Patient have hypovolemic shock as revealed in vital sign, patient tachycardia and low blood pressure.
What other causes for this shock?
It could be obstructive shock due to cardiac tamponade. It could be cardiogenic shock from cardiac contusion from trauma.
So why did this chest tube drain only 200 ml if it's a major vessel injury as suspected?
Okay, because chest tube insert in a pleural cavity and a major vessel located in mediastinum.
So what's your definitive management for aortic injury?
It could be open repair or endovascular repair.
What blood abnormalities you suggest in this patient would be fine?
Okay, patient have low hemoglobin, 8.9, and patient have metabolic acidosis.
Why this patient have metabolic acidosis?
As
Experiencing
patient have, as patient have closed femur fracture, may lead to compartment syndrome. Patient have hemorrhagic shock, and patient is diabetic, maybe diabetic ketoacidosis.
What additional investigations would you consider?
I will consider echocardiography, ECG, CT chest, abdomen, and pelvis with contrast if renal function is normal, and CT brain.
Regarding the abdomen, what findings suggest further exploration?
Patient have absent shadow of psoas muscle. This suggests retroperitoneal collection, and patient need exploratory laboratory.
So what other preparations you will make in the ambulance during the patient's transfer?
I will prepare oxygen, IV fluid, and initiate blood transfusion, cardiopulmonary resuscitation set, and extra chest tube in case the inserted one blocked, and information and communication technology.
If intubation is required during the transfer, who will you perform it?
It should be performed by anesthetist.
Thank you for the updates. Who will accompany this case?
I will come with the case and also with one of our anesthetist colleague.
Thank you, Dr. Alia, for the detailed information. Please proceed with referral and keep me updated with the progress.
All right,
Thank
good.
you.
Good presentation, Alia. And Hadi
You have
also,
2 minutes.
you asked all the question, and she still have 2 minutes. All right. What do you want to do in these 2 minutes?
Yes.
I don't think we need to summarize here.
I will. Yes,
Summarize
I
in-
wanted to give a tips about if you have remaining time as 2 minutes or 1 minute. If
Yeah.
you have a remaining time in
Yes.
the phone call station, please mention to the examiner what you will go treat this patient, your plan of action. So as this patient as kida, I will start by fluid resuscitation. Give the patient and thank the patient at the end. If you have a
Yes.
time.
Did he sign? Did he
But
sign
sir,
the paper?
question, how can I know that there is a remnant? Sorry, the time hasn't finished yet.
The
Okay,
examiner
that's
will
fine.
not
Okay,
ask you
so-
a question.
Yeah, no. Wait, Muhammad. You're gonna go to the station. After 6 minutes, the bell will ring. After this 6 minutes, the bell will ring. Then you still have 3 minutes. Then the bell will ring again. So when you hear the bell for the first time, that means you still have 3 minutes. If you didn't hear it again, that means you still have time. Let's say you started to summarize. You started to summarize, or you started to give the plan of action, and you heard the bell ring. That means you should go to the next, which is fine. Nobody will blame you for the normal. That's the normal of the exam. All right, Alia, good presentation. I think you answered everything question right. I'm just gonna ask Muhammad, can you check for me? Is it the descending aorta or the aortic arch? Is the most common in the
Descending
Indian?
aorta. It's a
Descending
descending
aorta is the
aorta.
most common.
Descending aorta written
Descending
clearly
aorta.
in the school. Yes, she's right.
All right,
Research about it. It's
that's
descending
fine.
aorta is the
And
perfect answer.
yes, okay. You just have couple of wrong pronunciation, Alia. You know, okay. Can you say short? Abdominal X-ray short. Can you say that, because this is a very common word to you?
Abdominal X-ray show.
No, not
Uh-huh.
show it. Short, short,
Okay.
not show
Oh.
it. Short, because you're gonna use it a lot. Short is very important.
Okay.
Can you say level?
Level.
Not you say level.
Level.
Like
Ah,
two
okay.
kasra. No, that's wrong. Level.
Level. Okay.
Just you patient have or has?
Patient should be has.
Yes. You said it like 4 times. Patient have. This is very common.
Yes.
So patient has, not
Ali.
patient have. Yeah,
I
Muhammad.
would like to remind everyone here, as Alia did in his presentation of the case, first mention what's your role, then your consultant, then the consultant you wanted to call him, then give details about the patient complaint, go through examination, investigation, and what did you do for this patient as management. All right.
Yeah.
Okay.
Yeah, and just focus on this couple of very important mistakes. Patient has, not have. Chest tube inserted, abdominal X-ray showed, and level, because you're going to use this a lot. Okay, should
The
we go
next
to the
station
next?
is the
But yeah,
post-operative
good presentation
oliguria.
of all. Very good presentation. You answered every question right.
Thank you.
Post-operative oliguria, I think, Iman,
Yes.
are you ready?
Yes. Who's going to be her consultant, Muhammad?
Hajer?
Yeah, can be Hajar, but I just want to know
Yes.
if anyone want to be a consultant for this patient.
Me,
Because Hajar already. Who is this?
Salma.
Salma, all right.
Okay, open school, Salma Manna.
Okay.
And when patient introduce himself, ask him to summarize the case, all right?
Okay.
Okay, just follow school. Now I will put a timer.
Iman, if your consultant forgot for whatever reason, you should encourage the consultation by saying, okay, I'm going to summarize my case. Even if you didn't,
Okay.
if your consultant didn't ask you about you, because you are the one who's searching for marks, not your
Yes.
consultant.
And
So
if
you will push the conversation forward.
Yes.
Okay, Mr. John, now I'm going to
Okay.
summarize my case for you.
Okay, Iman,
Then-
also if the examiner asks you a question, you didn't know it, just apologize and tell him I will check for it. As he asked you, did you request any CRB? Apologize and tell him that I will check for it, okay? Now start.
All right. Okay. Hello, sir. I am Dr. Iman Abdelgader, surgical house officer working for Mr. Matt. And I need to speak to the on-call consultant, Mr. David, to seek advice about a patient who had surgery 24 hours ago, and now he is oliguric. Can I confirm that I'm talking to Mr. David?
Yes. Hello. Yes. This is Mr. David. How can I assist you?
Yeah, we had a patient who underwent left hemicolectomy about 24 hours ago, and now the patient is oliguric. I
Can
need
you?
advice regarding this patient.
Okay. Can you provide me more information, please?
Yes, Mr. Smith, he's 55 years old, underwent right hemicolectomy with a liver biopsy. And 24 hours ago, the patient now, I have been called with the patient is oliguric. His urine output has been 10 to 20 ml per hour for the last 8 hours. Clinically, the patient is tachycardic, mildly hypotensive, and having a low-grade fever. Abdominal examination revealed the abdomen to be lax, and his investigation showed his hemoglobin to be dropped from the baseline with 2 milligrams from 12 to 10. Also, his urea is mild raised, and he had the borderline creatinine.
Okay. Do you think this patient is in shock? What could be the causes?
Yes, I suspect this patient is having a hypovolemic shock and maybe a septic shock, but most probably a hypovolemic shock.
What do you suspect is causing the oliguria?
This patient received, according to his fluid chart, received only 1.1 liter of normal saline post-operatively. So I think this is dehydration.
What are your plans for action?
I will start fluid challenge with 250 to 50 ml of normal saline or crystalloids as fast as possible. And I will repeat the fluid challenge up to 4 times or till 1.5 liter and assess the patient afterward.
Okay, what is the plan for fluid killing?
Assess the patient cardiovascular response and to assess the patient dehydrated is not or not.
Does he require an HDU transfer?
For now, I need to perform the fluid challenge first. If he does not respond, yes, I will call the HDU registrar. I will transfer the patient to the HDU for invasive monitoring and maybe entropic support.
If HDU is full, who will you speak to?
I will speak to the bed manager to facilitate discharge of stable patients or repartitioning of the patient.
Do you suspect bleeding or anastomotic leak?
It is possible, but for now, the bed abdomen is lax. I need to perform the fluid challenge first, and I will do serial abdominal examination. If the patient became peritonitic, I will inform you subsequently.
Does he require an operation now?
He may require operation, but we need to exclude the hypovolemia first, as it is the patient presentation and it is a common cause. But I will arrange for an abdominal ultrasound to be performed, and I will update you subsequently.
Does the patient need hemodialysis? What are the indications?
I don't think so. The patient does not need a hemodialysis for the indication may be for intractable hyperkalemia or for uremic encephalopathy or uremic pericarditis or pulmonary edema. Or if the patient is having an acidosis with pH less than 7.2.
Okay, Dr. Aman. Anything else?
No, sir. Thank you. I am going to sum up the plan of action for this patient. Is that okay?
Okay.
All right. As this patient is having symptoms suggestive for dehydration with low blood pressure and high pulse rate, I will start the fluid challenge, monitor the patient vital signs and urine output. If the patient is improving, that is okay. If he is not improving, I will refer him to the HDU after calling the HDU registrar and start invasive monitoring. I will repeat the patient hemoglobin and do an abdominal ultrasound, consider blood transfusion. And I will update you subsequently, sir.
Okay, thanks. Goodbye.
Thank you.
Yeah, Muhammad, how many minutes?
3 minutes. Excellent, Iman.
Good presentation. I just have two quick, and then we'll let Muhammad mention his point. Plan for fluid challenge. When she asked you plan for fluid challenge, you said the reason for the fluid challenge, but you didn't describe how we do the fluid challenge, right? Did you say we'll give 250 in 30 minutes and see the response, and if there's no response, we'll give another 250?
Yes. She said that until repeated 4 times. Just she didn't say 20 ml per kg. Just this answer, 20 ml per kg.
Yeah, she didn't prescribe the details, right, Iman? You didn't prescribe the details. You didn't tell us how.
I prescribed the details, but I didn't say the dose per kg. I said 250 to 500 ml as fast as possible and repeat it up to 4 times.
Are you sure you said that? I didn't hear it.
I hear
Yeah,
it.
that's
I hear
okay.
her.
She said
I
that,
hear
but
her.
she
She
didn't
said
say
that.
per kg.
She
She's
said
right.
that.
Said it in the previous question, not the question where she should have said 20 ml per kg, the dose.
Okay. And this patient, instead of this patient is having, I think it's better to say this patient has this, or this patient had this in the past or in the, but it's having is right. I don't think it's. You just, Iman, yes, you are very fluent. You did well. Just try to remove from your vocabulary. I think you say it a bit, well, a lot, right?
Yes, I did, yeah.
Revise this record later on when we upload it. Just don't mention a couple of times. Like, I think you say a lot. That's, I noticed it. Muhammad, but overall, good presentation.
Yeah, I have just 2 points. Iman, I think you didn't mention the patient have 2 units of blood transfusion. during the
No,
operation?
the
Yes.
intraoperative complication, yeah, I didn't get to it.
Yes. And the question when Iman asked you or Selma, does he require an operation? I think the answer is simple. Could
Maybe.
you? Yes. Overall, you did very good.
The answer, what the answer is simple. What's the answer? Can you give details?
Maybe.
Could you answer this
He
question?
should.
Does he require an operation now?
The patient may require an operation, but now we need to perform the fluid challenge first and do
Yes.
serial abdominal examination and ultrasound signs for prostration.
Yes, this is the answer.
Also
exactly.
blood investigation.
Excellent.
Also.
Otherwise, you did very good. Thank you.
Fine.
The
Cool.
next station
Is
common bile duct injury.
okay. Who's doing it?
Let me check.
My station.
Yeah,
Sahar.
Sahar.
It's
صدق،
common bile
okay.
duct Sahar. Who will
Who's
be
the
the examiner? Hajir or
Hajar or Iman? Who's one? Because Hajar is already became the patient. Okay, Hajar.
I can do it.
feel like it.
Iman, okay. Because have you been a patient now today?
No.
No.
Not patient. I mean a doctor.
Doctor consultant.
All right.
All right.
Then Iman and Sahar. Okay. Let's start. Muhammad, put the timer.
Let me put a time. Start.
My son, I hope you are. Meanwhile, you are in a cafe now or in a place that has
Yes,
stable
start.
connection. Let's start.
Okay. Hello, I am Dr. Sahar, one of the surgical doctors working with Mr. Raposo in University Hospital. I'm calling to speak to the hepatobiliary consultant regarding a patient with suspicion of biliary leakage. Can I please confirm that I'm speaking with the hepatobiliary consultant?
Yeah, it is Mr. Hamilton. How can I help you?
Nice to speak to you, Mr. Hamilton. Mr. Hamilton, I have a 50-year-old female who underwent an interval laparoscopic cholecystectomy a few days ago, precisely 2 days ago. But since the surgery, she's been experiencing abdominal pain, and we've noticed bile from her intra-abdominal drain. On clinical grounds, she seemed to be tachycardic, a high-grade fever, and slightly jaundiced. But upon examining her abdomen, it was with generalized tenderness, but lax overall. And in her labs, it revealed high bilirubin, a high total white count, and a high C-reactive protein as well. And what alerted us also an abdominal ultrasound on her that suggested a free intraperitoneal fluid collection. From the mentioned findings, we suspected biliary leakage, and we're hoping to transfer Mrs. Fatima to your specialized care for definitive management.
All right, doctor, is it an urgent situation?
I'm afraid, yes. We are afraid of developing biliary peritonitis.
What is biliary?
It is inflammation of the peritoneum caused by bile leakage into the peritoneal cavity. And it has reasons. It can result from thick duct leakage or the stump leakage due to slipped ligature or clips or retained common bile duct stone. It could be also due to biliary trauma or leakage from the liver bed or perforation of the gallbladder itself or an accessory cystic duct.
What is the most common cause of this?
It's probably a leakage from the cystic stump or injury to the biliary tree.
All right, did you perform
to the common bile
CRP?
duct? Yes, it was 250.
Is it an infection? I think it is an elevated.
Well, as we know, Dr. Hamilton, the CRP is an acute phase reactant protein, and it's
In this case, probably increased due to the recent surgery she's had.
What about her total blood count?
The total blood count was also high. It was like 17,000.
All right, and when were those blood taken?
Unfortunately, Dr. Hamilton, and I apologize for that, the blood tests were taken 2 days ago. But as soon as we get off this phone call, I'll make sure to send a new set of labs, and I'll update you with the results.
Okay, and what is the plan of management before referral of this patient? What are you going to do first?
Well, I will treat this patient according to the care of critically ill surgical patients using the ABCD approach. I'll give the patient IV intravenous fluids and intravenous antibiotics according to the hospital protocol, and after discussion with the microbiologist. I will, as I said, I will cover with broad spectrum antibiotics, and I may perform an ERCP to identify the source of leakage, and if there are any common bile duct stones, to retract them. But the stent, unfortunately, is not available in our hospital, hence my call.
Okay, what does ERCP stand for? How do we do it? How we do it?
Okay, it stands for endoscopic retrograde cholangiopancreatography, and it's basically an X-ray used to examine the common bile duct and the pancreatic duct. And during the procedure, the operator passes a flexible telescope down the esophagus into the duodenum, and a dye is injected into the hepatopancreatic ampulla of water. It delineates or visualizes the gallbladder and hepatic ducts and the biliary tree, and allows us to detect any leakage.
Okay, what is your expectation regarding this patient after transfer her? What are we going to do with her?
In regards to the management of the patient, doctor?
Yes, you are transferring this patient. You are transferring this patient. What do you expect us to do for her?
Okay, we in regards to the management, a stent placement or surgical operative management for biliary to assure biliary continuity, and using either Roux-en-Y, the choledochogegenostomy, or a choledocholdigenostomy anastomosis by bilioenteric anastomosis.
All right, doctor. There is no available beds in our hospital. What do you think we should do?
Okay, I will alert the bed managers. I'll inform them about the urgency of this transfer, and I'll inquire about the possibility of either discharging patients or repatriation of patients.
Okay. You can send it.
Okay, so in summary, Dr. Hamilton, I plan to treat the patient according to the CRISP protocol, and ordering a new set of labs as I promised, and hoping to find a bed with the help of the bed managers. Thank you for your time, and I will keep you updated, Dr. Hamilton.
All right, thank you.
Thank you.
Good.
Sorry.
That's pretty good.
I just have one comment.
Yeah.
It is should be Mr. the consultant.
Yeah.
We don't use doctor. Am I right?
Mr. is for the surgeons, yes, but also doctor.
Yeah. Iman first, Iman and Sahar, very good. I'm really happy with the performance. I'm not sure, are you good guys, or am I a good teacher?
Both.
I see.
We also give credit to ourselves. Both.
Actually, you are a very good teacher. You are taking big mistakes. That's why.
No, I think that's a perfect presentation. This should be ideal for the exam. That's pretty good. I can guarantee this a pass for sure. There's no doubt about this. I think your English is very good.
And the energy is better today, thankfully.
Yes. I don't have any point to mention. I think I just heard he is had. Am I right or correct? Did you mention a sentence like this? She is had?
She
I'm
has
not sure.
had. She's had. Yeah.
Yes, all right. Okay, she's had. That's fine. I don't have any point. If we like, I'm just asking the rest and Muhammad and for our group now. Do we have more questions regarding this station?
No, I think
Your
this is
presentation is
more than the question in the real exams.
enough. Yes, we always add new questions.
Yes. But
That's
reality
good.
about 10
Good.
question, 9 question.
Or less. Okay,
Yes.
that's pretty good then. And what I like, at the end, she also made a small summary of her treatment,
Yes.
which will make a standard for us whenever we have. And the communication in person, you leave the last 2 minutes for summary about the case. Here, you leave the last 2 minutes for your plan of action. Okay, Mr. John, I will do this and this and this and this. Good. That's pretty good.
Just one comment,
Thank you,
Dr. Ali.
Shahid.
Can you please add this note summary in the
Yes, you
Yes.
will do that.
yes with
I will do
but
that.
every station, yes, do summary if you had time. Just to know.
Yes, yes, and we will summarize that. Yes, I think that would be helpful. Yes. So we have 2 things to add to school today: how to use the drain, and this one, add the summary. All right.
I have no point about Sahar. You did very good. Just I would like to say let us go to the next station.
That's fine. Now, what's the next station?
Perforated viscous. Think for Salih.
Selma.
or-
Selma. All right.
Yes, me.
Selma or
Sahar,
Hajar.
can
Yeah.
you be the patient for Selma?
Ali, please.
Yes.
I think perforated viscous for Hajar
Sure.
because in the last station he forget his station. So Salih, tell us that everyone need to choose his station. Can you think Hajar the
I
first one
don't.
who choose? Then
I'm not
Selma.
sure, Muhammad. I'm not
Yeah.
sure. I don't know. You determine that. I don't know.
Yeah, let me return to the telegram.
Saleh in the first took it, but
Selma,
then
yes, you said that you first said that you want to take this station, but in the last station, Hajar didn't take his station.
yes,
So we
and
offer
after that
her,
I took it from Saleh.
we offer her to get a station in this
Just
session.
one suggestion, Dr. Mohammed Abikir. Is Dr. Saleh here with us now? You
Yes.
can ask
Yes.
him.
Saleh. Muhammad
No,
and Saleh.
I'm not. No. It's not
Muhammad,
Saleh,
what's the
Ali.
issue,
It's
Muhammad?
about Hajar.
But I cannot determine.
It's about Hajar.
Oh,
Okay.
sorry.
Hajar.
Selma and Hajar, both of them, they're gonna present
Yes.
the same station. Both of them. Selma and Hajar. They're gonna
Be the examiner and patient for each other.
yes.
Okay.
We're gonna start with Selma being the candidate now, and then we're gonna reverse it. Let's do it.
Okay.
Let me put a
أنا
timer,
هبقى
please.
doctor or هاجر؟
Hajar هتبقى الدكتور. then بعدك they're gonna reverse roles.
Hajar ولا
No, Ali, Hajar and Selma. Not
yes, me,
Sahar.
I'm doctor.
Yes.
I'm candidate. Hajar is doctor.
Yes. And then we're gonna reverse it. Hajar
Okay.
gonna be the candidate, and you're gonna be the doctor.
Yes.
Let's start.
Okay. Start.
Yes.
Yes.
Hello, I'm Dr. Salma, one of the surgical doctor. I would like to speak to ITU registrar for asking advice on recently admitted annual patient needed a laparotomy. Additionally, I would like to coordinate post-operative ITU bed. May I confirm that I'm speaking with ITU registrar?
Yes, can you summarize your case, please?
Okay, Mr. Wilson is 73 years old, patient with a COPD background with acute renal failure and perforated viscous. Clinically, this patient had abdominal abdominal tenderness and also abdominal distension, and the patient had hypotension and tachycardia and metabolic acidosis with high lactate. Also, his blood test shows that reveal hypokalemia and elevated creatinine level, and also hemoglobin had dropped in 2 units. And also his imaging shows that his abdominal ultrasound show free fluid, free intraperitoneal fluid, and also his chest X-ray clear with no air under diaphragm.
Okay, what medications is the patient taking for his COPD?
Taking steroid.
Do you have any plans regarding his steroids?
Yes, I will give him hydrocortisone, 100 milligram IV at the injection of the anesthesia.
Okay. Was an ECG performed?
I'm so sorry, I'm not sure, but I will check that and update you.
If it's available, what findings are you expecting?
Okay, this patient with hypokalemia, and also I expected that some manifestation of hypokalemia on ECG, and also has atrial fibrillation.
What's about fluid balance? Do you have any charts taken?
No chart were available, but I will check and update you.
Yeah. How will you monitor his response to fluids?
What?
How are you going to monitor his response to these fluids?
Monitor his response for this fluid?
Yes.
Yes, I will monitor with the heart rate, blood pressure, capillary fill, mental status, and urine output.
Was an urinary catheter inserted?
I'm not sure, but I double check and update you.
Who else would you contact?
I will contact with anesthesia registrar. Also, I will contact with my general surgical consultant.
Okay, did you check her oxygen level as she is COPD patient?
Unfortunately, I'm not checked, but I will do that immediately and I will update you.
Okay, how will you give the oxygen therapy?
Okay, this patient in non-case of COPD, I will give him oxygen with Venturi mask or nasal cannula 4 liters per minute to maintain his oxygen saturation from range 88 to 92%.
Why you took this approach?
Because this patient also has none of COPD and avoid for respiratory depression, as her respiration is driven by hypoxia.
Will you repeat the EPG after giving the oxygen?
Yes.
Did you give any antibiotics?
Not yet, but I will take sample for cultural sensitivity, and I will discuss that. I will give a broad spectrum antibiotic after discussion with microbiologist and according to the dress policy. And after that, if as a result of cultural sensitivity, I will give the antibiotic according to the type and duration.
Do we need to give this patient more blood because his hemoglobin is going down?
I will do blood grouping, cross-matching. Also, I will consult the hematologist and anesthesia for further advice.
What's the treatment of atrial fibrillation in this patient?
I will correct the underlying cause. And in these patients, underlying cause is electrolyte disturbance like hypokalemia. I will go for treatment.
Okay, is ICU admission necessary?
Yes, this patient with COPD, and that is my suspected respiratory depression post-operatively, and he need mechanical ventilation. Also, he had renal failure. These two symptoms system impaired that it may require for ITU admission.
Okay, what if only ITU bed is available and we had an asthmatic patient arrives first?
Okay, I will continue and monitor my patient in recovery room. If available any ITU bed, I will admit it.
Is he
I
surgery?
will admit it him in. Okay.
Is his surgery considered risky or not?
Yes, it is a very significant risk of my patient, and it is urgent and needed to do it, and also to optimize pre-operative my patient.
Okay. Thank you for your time.
You have 2 minutes remain.
Thank you, doctor.
Selma, you have 2 minutes.
Can you
Okay.
summarize the case?
Okay, you advise me and for administration of fluid and ask me for inserted for optimizing steroid.
Can you summarize your plan of action for this patient?
Yes. Plan of action for this patient in the first for steroid and administration of fluid and monitor the response of the fluid given to the patient. Also for oxygen therapy, this patient is known case of COPD, and monitor ABG, and also administration of antibiotic according to culture and sensitivity and discussion with microbiologist, and also blood transfusion if the patient dropped 2 units of blood, and also treating the atrial fibrillation and electrolyte disturbance, and ICU admission is necessary for this patient, and the operation is a significant risk of my patient.
Okay, thank you.
Okay, good presentation. Quick points. Selma,
Okay.
there's your presentation is very good. There's a couple of clinical problems. There's couple. Now, you just give me 1 minute. Yeah, there's a couple of mistakes that we need to practice on. You said I will contact with my registrar. Do you think that's the right sentence? I will contact with my registrar, or I will contact my registrar, or I will discuss with my registrar, or I will discuss with my senior. You said I will contact with my registrar. That's not right.
Okay.
I'm not check. You said I'm not check. That's not right, the sentence. I didn't check yet, or I'm gonna check later on, but I'm not check. There's no sentence like that. You said this patient has none of COPD. You can say this patient is none of COPD, not this patient has none of COPD. I will for the bloods when she asked you about the hemoglobin, you said I will cross match and I will speak with the hematologist, but you didn't say generally the patient doesn't need any blood at the moment.
Yes,
because
I didn't say.
Yes, yeah. So you will check with the blood. You do cross matching. You will check with the hematologist, but for now the patient doesn't need any blood.
Okay.
That it may require, and you said it's urgent and needed to do it. It's urgent and I need to do it. For example, generally you answered every single question right, but Selma, I think you need to work on the grammar. You need to listen. You need to listen first. Listen to the videos, and then listen to your presentation now. When we upload this video, there's a couple of, I'm not sure if, I don't think, okay, you need to practice this more, you need to do it more. All right?
Right.
Yes. there's small mistakes in the grammar, but overall, as we said, I'm trying to be perfectionist with you guys. Grammar, some people say grammar is not important in the exam, but that's not right. Grammar is very important. Why? Because you may have your exam with a native speaker. We already have an accent. Imagine you have an accent and you put on top of it a lot of grammatical mistake. So I will make sure that you grammatically correct and clinically correct. This will make a difference. My advice, I want you to record this station yourself with your voice from A to Z, couple of times. All right? Record it from A to Z according to the school, 3-4 times. And listen to your recording. Okay.
Okay, thank you.
Thank you.
But good, overall, good presentation. You're gonna pass with this presentation. But we want to make sure that even on the exam when you are stressed, you will perform well. All right?
Thank you. I appreciate that.
Okay, the next station is, I think Maysoon left the room. We have update head trauma. Hajir, if you're ready, you can take this station. Update trauma here. Or you can choose your station.
No.
Okay.
Okay. We said Hajir can do
Do the
reverse.
same.
Hajir,
Yes. Do the same station.
Yes.
Salma, be the examiner.
Okay.
Okay.
Let me put the time.
Can I start?
Let me put the timer.
With the
please.
timer, Muhammad.
Okay.
And
now you can
meanwhile,
start.
meanwhile, I want someone of you guys to prepare for the next station, head trauma. If you can just read through, and then we're gonna practice it with you.
Okay.
I can Sahar, that's fine. So then if my son didn't arrive, Sahar will do the head trauma, okay?
Now Hajir,
Muhammad,
Salma.
you're gonna follow up with the timer and follow up exactly with Hajir during her presentation.
All right. Start.
Okay. Hello, I'm Dr. Hadir, a clinical fellow here. I would like to speak to the ITU registrar for guidance on recently admitted unwell patient who is needing laparotomy. And I would like to coordinate a post-operative ITU bed. May I confirm that I'm speaking with an ITU registrar?
Yes. Can you summarize your case?
Okay. Mr. Wilson, 73 years old patient with COPD, acute renal failure, and perforated viscous. Clinically, he has severe abdominal tenderness, distension. He is hypotensive, tachycardic with metabolic acidosis and high lactate. Regarding his blood test, it shows hypokalemia, elevated creatinine, and 2-unit drop in hemoglobin. We found the free intraperitoneal fluid on ultrasound with clear chest X-ray.
Okay, what medication is the patient taking for COPD?
He is taking steroids.
Any plans regarding the steroids?
Yes, I will administer 100 milligram IV hydrocortisone as induction.
Was an ECG performed?
I'm not sure, but I will check and update you.
If available, what findings are expected?
I do expect to find hypokalemia, and maybe I will find atrial fibrillation.
What about fluid balance? Any charts taken?
Actually, no chart were available, but our plan include fluid resuscitation with 1 to 1.5 liter of Hartmann solution for 1 hour, and inserting a urinary catheter for monitoring.
How will you monitor his response to fluids?
I will monitor the response by monitoring the heart rate, blood pressure, capillary refilling time, his mental status, and his urine output.
Was a urinary catheter inserted?
I'm not sure, to be honest, but I will check and update you.
Who else would you contact?
I will contact the anesthesia registrar and the general surgery consultant.
Your patient has COPD. Did you check her oxygen level?
Unfortunately, no, but I will do it immediately and let you know after this call immediately.
How will you give oxygen therapy?
I'm going to use venturi mask or by nasal cannula at 4 liters per minute to maintain his oxygen saturation between 88 to 92%.
Okay. Why is this approach?
Actually, this patient has a COPD, so he has hypoxia, and I want to avoid any respiratory depression that may occur.
Okay. Will you repeat ABG after giving oxygen?
Yes, I will do that definitely.
Did you give antibiotics?
Not yet, but I will take sample for culture and sensitivity, and I follow the trust protocol, and I will consult a microbiologist to take the appropriate antibiotic for the patient.
Okay. We need to give the patient more blood because his hemoglobin is going down.
Yes, I'm going to start by doing blood grouping and cross matching, and then I will consult a hematologist and anesthetist for further advice regarding blood transfusion.
What is the treatment of atrial fibrillation of this patient?
Firstly, I must treat the underlying cause and address any electrolyte disturbance.
Is ICU admission necessary?
Yes, for sure, because this patient has COPD and renal failure, and he for sure need the ITU care.
What if only ITU bed is available and an asthmatic patient arrives first?
Well, I will continue monitoring the patient at the recovery room until the bed is available and the other patient is stable.
Is the surgery risky?
Yes, it actually carries a significant risk, but in the same time, it's considered an urgent and necessary operation. So we need to do optimization preoperatively. I'm going to summarize the management, our discussion on management. It include administration of fluids and inserting catheter. We need to provide oxygen therapy and monitor his ABGs. We need to optimize his steroids and administer antibiotics according to culture and sensitivity. We should consider blood transfusion, and we should treat any atrial fibrillations, and of course we need an ICU admission.
Okay.
Thank you for the time, Mr. Allison.
Thank you.
You did the session in the 7 minutes. You have 3 minutes remain. You did very good, Hajir. You answer all questions perfectly. Thank you, Selma, for participation. Just let us go to the next station. Is Ali.
Nobody to catch him, that's why.
Acute limb ischemia. The last
Is it
station.
acute limb ischemia or the other one?
The other one.
I have a question regarding
Is my Sumba?
the last session.
You can ask him, man.
On a practical point, like when you finish consultation, when do you document it?
What did you say?
Immediately after we finish. Let's say now.
So if the name of the consultant is not provided on the stem or in the file, I think we should ask about the name so we can document the call.
We usually ask about the name, and then we write it on the EBR
Ali,
or in the
in my exam, the examiner name not written in the card, but he tell me by on himself that I am Dr. John. Can you tell me Mr. John?
Okay, that's fine.
He will tell you his name.
But she said from the practical point. She what does she mean? She mean in the real life, right? Or am I wrong?
Yes.
In the real life, yes. If we know the name, okay. Let's say I call orthopedic surgeon. I spoke with him or her, and at the end, I will ask, can I get your name just for the sake of the documentation? And if I forget, I will say I spoke with the orthopedic surgeon on extension or on bleep number, and then he advised of this and that and that and that, and that's it.
Okay.
All right. If my son is back, then we're gonna do the station, or if she's not, then Sahar gonna do it.
She left the station, I think.
My son is
Sahar,
not here, so Sahar
are you
gonna
ready?
do the last one.
Sure.
Okay. Let me put the time. Five minutes. Start.
Hello, I'm Dr. Sahar, one of the surgical doctors. I'm calling to give an update on a trauma case that landed in our ER. May I confirm that I'm speaking with the head of trauma?
Yes, you can call me Muhammad.
Hello, Dr. Muhammad. Nice speaking to you. I have this 21-year-old male who landed in our ER after following a road traffic accident that took place around 3:30 p.m. He had a Glasgow Coma scale of 15 initially. He then had a transient loss of consciousness. Hemodynamically, he was stable, but clinically there was a swollen right hand, a swollen and painful left lower limb, and some abrasions on the left upper abdomen. His imaging of X-ray showed a fracture of the right hand and his left tibia and fibula. His ultrasound or FAST showed free intra-abdominal collection. His labs were normal. Initially, he was given tetanus toxoid and he was covered with antibiotics, and we gave him also fluids. But 8 hours later, specifically at around 11 p.m., his left leg started to show signs of ischemia in the form of absent pulses and paleness and worsening pain.
All right. Could you tell me what the most urgent issue with this patient?
Urgent issue would be a vascular injury, arterial damage, and compartment syndrome.
Okay. And why you called me?
I called because he may need an urgent overnight surgery to save his limb.
Could you tell me the possible causes of pulselessness in his foot?
Sure, doctor. It could be compartment syndrome or vascular injury or kinking of a blood vessel or spasm, arterial spasm.
If I ask you what other investigation you need to order?
I do an arterial duplex ultrasound and a CT angiogram.
All right. Is the patient wearing a C-collar?
Oh, I'm so sorry. I'm not sure. I will check and update you, doctor.
Okay. How about the patient fluid chart? The patient dehydrated.
I'm sorry again. I'm not sure. I will check and update you.
All right. How to manage this patient if they arrive in the emergency room?
Well, I will follow the acute trauma life support protocol using the ABCD approach.
Acute trauma? Or what did you say?
Sorry, advanced trauma life support.
And you will start by ABCD approach. Right.
Yes, using the ABCD approach.
Okay. And what plan of action should be taken now?
Well, first I will secure the airway, I will immobilize the cervical by a heart collar, by triple immobilization, and I will also give a traction or immobilize the foot, the hand and the leg fracture. And I will call in the vascular and orthopedic consultants and order the imaging in forms of CT scans.
Okay. Could you tell me what what we need to do before the patient go to the theater?
I will resuscitate the patient. I will administer the IV intravenous fluids. I'll give him painkillers. I'll do traction for the fractures and cover the wound without washing, and cover him with antibiotics and the anti-tetanus
All right. What's the
already
approach for
given.
wound management?
For the wound management, we'll do a debridement in the theater within 24 hours. That to reduce the infection risk.
Could you tell me what is the necessary blood investigation we need to request?
Yes, basic labs like complete blood count, CRP, cross-matching and blood grouping, liver and renal function tests.
Good. How to fix the fracture and why?
By externally fixing it. And this is for initial stabilization and to provide also access for any interventions and further assessments.
Why was an ultrasound requested for the abdomen?
As I mentioned earlier, he had abrasions on the left upper abdomen. So this raised suspicion of the splenic injury.
Who may need to be contacted before or during the operation?
Of course, I'll call
vascular
in.
and orthopedic consultant, right? What else?
Yes, I mentioned the vascular ortho, general surgeon, the anesthetist, of course, the plastic and the neurosurgeons.
You mentioned plastic surgeon. Why you need to involve this plastic surgeon?
In case the patient needs grafting for the open fracture he has.
And why general surgeon?
General surgeon for the suspected intra-abdominal injury to rule it out, and for the compartment syndrome and for the debridement of the wounds.
Right. What is the approach if there free fluid in the abdomen?
Emergent laparotomy.
All right. You have anything you want to add, Sahar?
No, I just want to thank you for giving me your time, and I'd like to summarize.
All right.
Okay, so this 21-year-old male who landed in the ER after a road traffic accident, initially had injury to his upper and lower limbs and abdominal injuries, which were superficial. Imaging showed fractures of the hand and the lower left limb, and the ultrasound abdomen showed free intraperitoneal fluid. I'd call in the necessary concerned specialties for the management of this patient. We gave him fluids, administered antibiotics and tetanus toxoid, and the definite treatment would be in the form of traction or external fixation initially, and wound debridement after 24 hours in the theater, and we call in the vascular and pardon?
The ringle. Thank you so much. I'm finished.
Thank you.
Excellent, Sahar. Very good.
It's excellent, like the previous one.
Thank you.
Yeah, which is very good. I don't have any comment to. It's just at the end, instead of you summarize everything, just summarize the plan of action.
The plan of action, yes. Yes.
Instead of summarizing everything.
I will tell you this
You
patient
summarize
approach advanced trauma life support, start by ABCD approach. That's all.
You summarize everything in the phone, in the person, yeah. Here, he knows you already told him just plan of action. Now we're going to do this, this, and this, and this, and that. Thank you. All right? Cool. We finished, right, Muhammad?
Yes.
Okay. Next is
examination.
Yeah, examination. What do you think, guys?
Acute limb ischemia, guys?
Yes, we did acute limb ischemia.
Did I miss acute limb ischemia?
Yeah.
I am missed, or what do you mean?
No, we didn't do limb ischemia.
Acute limb ischemia. There's one station remaining.
Acute limb ischemia. Is it in our plan today?
Acute limb ischemia. Who will do it? Oh, we did it. lower limb ischemia, Alia. Asia, I'm really sorry.
Done. Acute limb ischemia done, my
Yes.
my
No,
friend.
no.
It's already explained. Yes,
No,
done.
there are two
No, it is
acute limb
not done.
ischemia, which with diverticulitis and which with trauma. Asia have acute limb ischemia associated with diverticulitis, I think. Asia, are you ready? Asia? Asia. ليه الميتنج وقف كده؟ علي. Hello guys.
Regardless
I
of
lost,
yeah,
I
Asia.
lost
Okay,
my
so
internet
Asia,
connection.
tomorrow we're gonna start with you with the acute limb ischemia. To Asia, yeah, Muhammad. We're gonna do it tomorrow. There's another acute limb ischemia. The acute limb ischemia will be done tomorrow by Asia.
Ali?
We'll start with this one before we're going to the examination. Yes,
Ali,
Muhammad.
we can do it now.
No. I need to travel. I'm going back. I can't. Time. I won't be able to attend. Okay, that's fine. But I need to log out now. I can leave you guys on the meeting, but I will not attend. This means if I close the meeting, everyone will be closed, Muhammad.
Oh.
So we can do it tomorrow. That's okay.
Okay, no problem. Okay.
Yeah, we will do it tomorrow, and then I will go to the examination. For the examination, we need camera open. Prepare yourself. Cover practice with, and maybe your little brother or your son or your daughter. We need a practical boy with a consent. Take a consent. I'm not sure like how we're gonna do that exactly.
We can
but
figure
we
that,
need
Ali.
Yes. So
I can
now
do the examination by open my camera.
We're gonna.
We will discuss that later on.
That's fine. But I want everyone now. We have 12 here. Please give us your ideas for the examination starting from tomorrow, right? Tomorrow we're gonna start the examination.
Tomorrow?
Yes,
right?
yes, you're
Tomorrow
right.
is the examination, right, Muhammad?
You're right,
Yes.
Dr. Ali.
Yes.
Yes,
So
tomorrow examination.
yeah, everyone prepare yourself. See how you're gonna practice. Who you're gonna practice with? We're gonna the meeting is not finished. Let's just